All right, we are now live. So welcome everyone from coast to coast to coast, whether it's afternoon or evening for you. Thanks so much for joining us on another edition of our continuing education webinar series. This is the first of several as a part of its own contained series, which we're really excited to be doing in partnership with Perfuse Medtec or geko device and the Canadian Home Care Association. The whole webinar series as a whole is called Advanced Wound Strategies for Lower Limb Care. And we're so excited to be starting off our series with today's topic, which is on leg ulcers that aren't venous. Are you up to the challenge? And while I do a couple little housekeeping items, I'll maybe just ask Andrew behind the scenes here and Dr. Sibbald to get to put up the slides. And just to let everybody know, we are going to be recording today's session. So if you don't have a chance to stay on the entire time, or if you have a colleague you know that wants to watch a little bit afterwards, you can definitely do so, and it'll be on our NSWAC website after the fact. I see everybody's already posting in the chat. Didn't even need me to do so, but if you haven't already, please type in the chat where you're tuning in from. We got people from Montreal, Mississauga, Wallaceburg, Kingston, Shelbourne, Halifax, Vaughan, Kelowna. There we go. So now that brings us completely across the country. That's fantastic. Great to see everybody. Alrighty, well, I'm Troy Curtis. I'm their Director of Operations for NSWAC, and I'm delighted to be helping moderate some of the Q&A at the end of today's session, which brings me to my next point, which is if you do have questions throughout today's presentation, please do ask them. I'll just ask that you put them in the Q&A toolbox rather than the chat, and that'll make it easy for us to collate all the answers or questions and make it easy for Dr. Sibbald to get to all those questions too. So it's my privilege today to be introducing our speaker for today, Dr. Gary Sibbald, who's a renowned dermatologist and internist and founder and executive director of Woundpedia and the lead of Project Echo Ontario Skin and Wound. He's also a professor of medicine and public health at the University of Toronto and serves as director of the Masters of Science in Community Health, specializing in prevention and wound care at the Dalla Lana School of Public Health. And Dr. Sibbald's contributions in wound care are extensive, including being the co-founder and course director of the International Interprofessional Wound Care course, or IWCC, former president of the World Union of Wound Healing Societies, co-editor and chapter author of the Chronic Wound Care textbook, and currently co-editor-in-chief of Advances in Skin and Wound Care. With over 200 publications and decades of clinical and educational experience, he's widely recognized as an international key opinion leader in wound care, and we're so happy to have him on again. So without further ado, I'll pass it over to you, Dr. Sibbald.
Thanks very much, Troy. And we are going to delve into the diagnosis of leg ulcers and look at some of the therapeutic and diagnostic dilemmas. And on the next slide, my conflicts of interest are mostly Ministry of Health, where half of my time is spent with Project Echo. Chymoseptine got us to the Philippines. Perfuse, I am a consultant and investigator. And of course, my university and courses. Next. We are going to review diagnostic criteria for blisters. A vesicle is a blister less than a centimeter, and a bulla is a blister greater than a centimeter. A papule is an elevated solid lesion less than a centimeter, and a plaque is greater than a centimeter. And an ulcer is a loss of epidermis with a dermal or deeper base. We're going to evaluate diagnostic testing and differential diagnosis and assess treatment. Next slide. I want to know who you are, and I want you to pick the highest that applies to you. Paraprofessional, nurse, RPN, LPN, nurse, RN, nurse educator, advanced practice, nurse practitioner, nurse NSWAC, physician, allied health, chiropodist, OTPT, etc., and other. But please, in the chat, tell us what your other is, and that would be very useful to us. So we'd like to know who's here and what your background is.
And I've just shared the results there, and in the chat we've got lots of RPNs, LPNs, SWANs, chiropodists as well, and community paramedics in the chat too. But you can see the results in front of you now.
Okay, that's great. Thank you. And let's go on to the next slide. And here's another vote. What's your most likely diagnosis? You see a raised border, a central ulcer, There's a few satellite lesions. Is this pyoderma gangrenosum, bullous pemphigoid, erythema multiforme, vasculitis, or necrotizing fasciitis? And some of these, by the end of the talk, you will be more familiar with. So please enter and sign in, please. And let's see what you think.
And you should be able to see the results in front of you.
Okay, pyoderma gangrenosum is in fact correct. And let's go on to the next slide. So 50% are associated with diseases, and these include inflammatory bowel, so Crohn's or ulcerative colitis, rheumatoid arthritis, other inflammatory arthritides, and myeloproliferative diseases. Pathergy means trauma, so if you were to debride that active edge, you'd make a bigger lesion because it's really a ball of neutrophils destroying the environment. And so you need to watch for the active border and avoid debridement. Do not use strong adhesive dressings and the need for adequate pain medication. And for heaven's sakes, do not put iodine on these wounds because these are inflammatory wounds and we really don't want to do that. Next slide. Okay, so this neutrophilic dermatoses can be limited or aggressive. You see the association, including some less common syndromes and ANCA. Investigations, we do blood counts. We plasma protein electrophoresis looking for myeloproliferative disease, rheumatoid factor, ANCA in selected cases, and a GI workup because sometimes this can be the presenting complaint of inflammatory bowel disease. Next slide. What would you use topically? Protopic ointment, topical steroid, ionized silver dressing, inidine, or cadexamer iodine.
All right, we got about over 100 responding, so you should be able to see the results now.
Okay, topical clobetasol. That certainly is an option. This is a steroid that is 12 times the potency of 1% hydrocortisone. It will, though, help decrease the inflammation, but it may interfere with collagen synthesis, whereas protopic ointment, if applied topically, would actually help the healing process and act as an anti-inflammatory. But we often put, because it's an ointment, around the outside, and we put something else that's relatively neutral in the center. Inidine or iodine dressings are pro-inflammatory, and you're treating an inflammatory condition, as is cadexamer iodine, so that we're probably best avoiding iodine here if at all possible. And sometimes using a dressing that doesn't come out of the dressing itself. So Bactigras has chlorhexidine in the center. PHMB gauze or foam has the PHMB polyhexyl methylene biguanide. That's also in Prontosan solution. So that would be something you could consider. Next one. Okay. When we look at investigations, we see here the workup because you may have a silent inflammatory bowel disease, and then you need to treat the underlying cause if you've got one of these. The steroids, either topical or interlesional, and I would inject into the edges, and you'll see in some of these, the edges are flat, so this sometimes has to be treated as an infection, in which case our strategy may change and you may want an iodine type of dressing at this stage. Topical calcineurin inhibitors, so there is Protopic or Elidel cream. Protopic's a little bit stronger than Elidel. Elidel's a cream and Protopic's an ointment. Ordered in Ontario, it has a limited use. Oral doxycycline or sulfasalazine is a little bit safer and less hemolysis than dapsone. Second line would be oral prednisone or cyclosporin, and if these become circumferential within a few days, we really have to do either oral or even IV steroids, dexamethasone or solumedrol and cyclosporin. And these are immune suppressive drugs if we're looking at cyclosporin rather than anti-inflammatory. Next. Here is, I think, the biggest new piece of news, and this is Mevarex, and this is in JAMA Derm, and it's a diagnostic criteria. So instead of a diagnosis of an exclusion, it is a diagnosis of inclusion. And the major criteria that should be present is a biopsy of the edge demonstrating a neutrophilic infiltrate. And if you consider rebiopsying, if you've got a resolving and not a new lesion. And there are 8 minor criteria. If you have 4 or more of these minor criteria, it's again more likely to be pyoderma gangrenosum. So this is a big breakthrough, and there are lots of sessions teaching you how to do skin biopsies, and it's something everybody should consider down the road as scopes of practice are being increased across the country. Exclusion of infection. You may do the histology to check for bacteria, atypical mycobacteria or deep fungus, unusual infections like virus, which may relate to erythema multiforme. Pathergy is the ulcer occurring or expanding at a site of trauma. Inflammatory bowel disease, either a history or inflammatory arthritis, the rheumatoid arthritis being the most common. Papule, it evolves rapidly into a pustule, vesicle, and ulcerates. Clinical or photo evidence of a single lesion with peripheral erythema, undermined border and tenderness. Clinical or photo evidence of multiple lesions with one on the lower leg. Clinical or photo evidence of the scar. And the scar, when you actually compress it, it has a cribiform or wrinkled paper, cigarette paper type of scarring. And treatment is a decrease in ulcer size within 1 month of initiating immunosuppressive medications. So this is worth taking a picture of, and this really comes into play when we're making this diagnosis now. And it is a diagnosis of inclusion, not exclusion. Next slide. What's the most likely diagnosis here? You see a necrotic area in the area of the upper Achilles tendon. Is this traumatic bullous pemphigoid, hypertensive ischemic ulcer, vasculitis, or necrotizing fasciitis? And I'll wait till Troy stops the vote.
And we're over about 100 now, so you should be able to see the results in front of you.
Okay, so hypertensive ischemic ulcer is correct. And we'll see some of these other diagnoses as we go along. Next one. It's a painful wound with a necrotic base. It's often on the lateral dorsal aspect of the calf or Achilles tendon. Hypertension and sometimes diabetes. Pain is not exacerbated by exercise and leg elevation. So that rules out pure arterial ischemia. Diagnosis, history, and clinical confirmed with a deep elliptical skin biopsy of the wound border to fascia. So that's something that you would probably have to get a surgeon to help you with this, or a wound healer that has advanced experience. And you can see an ulceration in this case further down at the base of the Achilles tendon. Surgery is the most rapid and effective treatment. Necrosectomy is removing the dead tissue in a skin graft, but you can often feel very lightly around this a plate of calcium. And that plate of calcium tells you that there's something wrong and calcification elsewhere. And so this is very similar to calciphylaxis that you may see in end-stage renal disease or with parathyroid disorders, or sometimes with obesity. Next slide. And clinically, extremely tender. You can get a livido or a net-like pattern around it. And when you look at the biopsy, there's calcification of the medial part of the artery, subintimal fibrosis, stenosis of arterioles, and thrombotic occlusion. And because you occlude the arteries in the mid-dermis, this leads to cutaneous necrosis, or the black areas, and death of the cells above it because they don't have the candelabra of vessels feeding it. Next one. So an arterial ulcer is common on the lower extremities. It's a punched out appearance with well-defined borders, cold or cool to touch. Dependent rubor, it's red. It blanches with elevation. It's usually deep with possible tendon and or bone exposure, scant or no exudate or peri-wound edema, except some cases of infection or other causes of edema. Yellow slough or a black eschar with minimal or no granulation, associated with moderate to severe pain, plus or minus gangrene, and you see the black toes, which is most common. The circular defects there often occur with infection locally and folliculitis or furuncles or staph infection, and you very seldom see round ulcers with the tendon in the base in venous disease. And you can see in the left upper one that there's a tendon exposed at the base of this ulcer. That's often seen with smokers. And less reliable signs are pale, shiny, dry peri-wound skin with loss of hair and dystrophic nails. Next slide. It's 4 or more times more prevalent in persons with diabetes. Typically, the distal leg, tibial, and perineal arteries are involved. Pedal arteries are often spared. Contributing factors include smoking, hypertension, or hyperlipidemia, so that we have a lot of things going on here for sure. Next one, and this is the metabolic syndrome. And claudication in the calf muscle, if it's at rest or sudden onset at night when patient is lying in bed, the legs are up and gravity isn't helping. Absent pulses or cold feet, redness on dangling, which is dependent rubor, and paler on elevation, it goes white. Less reliable signs are the thin, skyny skin, absent hair on the lower extremity, or thickened nails. Next slide. I like simple things, and this is worth taking a picture. Fontaine classification. Class 1 is asymptomatic peripheral vascular disease found on testing. Number 2 is symptoms of intermittent claudication, where you get pain in the calf with ambulation. 3 is pain at rest, and 4 is necrosis and gangrene, which is a complete block and death of cells. Next slide. This is the geko, and this is a therapeutic device that can be used, put around the perineal nerve, and on the next slide. It's positioned the fibular head to stimulate the common perineal nerve, worn for 12 hours a day, 7 days a week. Each device lasts 2 days. 3 electrodes provide comfort, ease of fitting, 10 levels of stimulation, and even in patients with advanced diabetes and neuropathy, we're getting a twitch response of the ankle, which really helps to increase the circulation in the lower aspect of the calf and the foot. And it's wristwatch size, battery operated, self-contained, self-retentive. Next slide. And here on the left, you see with the geko off, this is a speckle image of a patient with a venous ulcer. And Keith Harding has shown some really good studies of venous ulcers where the patient was randomized to the geko plus compression versus compression alone. And we're getting many times the circulation, both in the gaiter area or the lower third of the calf and the foot, out of this device and out of the twitch response. So this is something very useful, very worthwhile. It's in a lot of long-term care homes in Ontario. It's not at the present time easily available in home care, but you should try and order it if you can. Next slide. And this muscle pump activating device, MPA, the physiological effect with the laser Doppler flux, which you saw in laser speckle, contrast image on the dorsum of the foot. And for peripheral arterial disease ulcers and diabetic foot ulcers and venous leg ulcers, it increases the flux on the foot and leg and the laser speckle contrast image on the wound and peri-wound area. So it really increases the circulation. And really interesting in Professor Harding's group study was that it doubled the healing rate when you were looking at 8 weeks, but the doubling of the rate continued even after the geko was discontinued at week 12 and 16. I do have a conflict, as I said at the beginning, in that I do act as a consultant for Perfuse. Next one. And I think in case studies, we found reduced pain, increased healing, and there are cohort studies of DFU, and there is a random controlled study for venous leg ulcers. So it is something new in our toolbox. It really works on the lower leg and foot, and it's got some advantages with the big twitch response than when looking at electrical stimulation, which may be what you need for a similar action, but less and less muscle action if you use it elsewhere on the body. Next one. And there's the twice the healing rate and the increased healing rate. Next. And the Canadian consensus statement, ABPI is reduced to greater than 0.5 where the patient's not able to tolerate compression. Apply a lower compression than the patient will tolerate. So this may be edema-aware or TubiGrip, which edema-aware works by compression at the various intersections of the fabric, and that's called a fuzzy whale. TubiGrip exerts about 8 millimeters of mercury per layer of TubiGrip, and that's very unlikely to interfere with arterial circulation. But we want extra caution with ABPIs between 0.5 and 0.65. The muscle pump activator, in addition to compression that the patient can tolerate, and if not tolerate, it may replace the compression. Recommend daily leg elevation above the level of the heart and regular exercise, because that also stimulates the calf muscle pump. Next one. What's the most likely diagnosis here? Traumatic ulcer, bullous pemphigoid, pigmentary purpura, vasculitis, or necrotizing fasciitis. Enter and sign in, please. All right.
All right, and you should be able to see the results now.
Okay, so pigmentary purpura is the most common, but pigmentary purpura will not ulcerate or break down. And you see either erosion, which is loss of epidermis with an epidermal base, or ulcers in 2 areas there. So this is actually necrotizing vasculitis. Next slide. And this is what cutaneous vasculitis looks like. The lower legs are very prone because there's the greatest cooling, the greatest thickening of the blood, reduplication of basement membrane, and there is the gravitational force. So immune complexes trap here. The upper left is a cutaneous vasculitis of polymorphs, and the one lower down is really at the epidermal junction, so that's the medium-sized vessels. The one on the right side could either be a vasculitis, and it could affect, that could be a lymphocytic vasculitis, but it could also be something else, and we'll come back to that in a little bit. The last one are nodules, and That can be anywhere from the epidermal junction to the subcutaneous fat. Next slide. And here we see the showers of purpura, and they're palpable. When you put your finger over them, you can feel them, whereas in pigmentary purpura, it's flat, and it's much more uniform than this. Next slide. History, you'll need to look at drugs preceding illness. Systemic involvement is common in the joints, liver, and kidney. It's uncommon in the GI, heart, lung, and brain. And we do lab CBC, liver, kidney. You look for hepatitis B and C. Hep C can often have vasculitis, and it may be generalized over the body, as can HIV. Specialized test, skin biopsy, regular histology from a new lesion. And we do immunofluorescence looking for immune complexes within the blood vessel wall. Lupus screen, it is more common with connective tissue disease, so anti-nuclear factor, rheumatoid factor, ENA, which is extractable nuclear antigen, complement, and anti-DNA. Selected patients, you need to look for cocaine, especially if it's laced with levamisole, and malignancy screen. Next slide. First line observation, remove the cause. Colchicine is anti-inflammatory, especially for polymorphs. Dapsone, but you get a lot of hemolysis, especially in the elderly or the very young. So sulfasalazine, 500 milligrams 3 times a day might be safer than dapsone or non-steroidal anti-inflammatories, but you really need to watch that in people over 65. Second and third line, oral prednisone, anti-inflammatory, cyclophosphamide, and other immunosuppressives. Antihistamines sometimes help if itch and even some burning. Trentol will help red blood cell contractility. It's anti-inflammatory and fibrinolytic. It's got more evidence in venous disease than in this, however, and IVIG is intravenous immune globulin. And so we have lots of choices, and it depends on whether they need treatment or it's self-limited when you eliminate or treat the cause. Next slide. What's this? Is this a traumatic ulcer, bullous pemphigoid, pigmentary purpura, cellulitis, or necrotizing fasciitis? What do you think this one is? And I think one of the most important things to note here is that we have hemorrhage within the blister, and which looks like a cellulitis around it. And so if we get the answers put up.
You should be able to see them now.
Okay, bullous pemphigoid is not quite right, and this is an important thing not to miss. And in bullous pemphigoid, the blisters generally don't have that level of hemorrhage in them, and the base is much more irregular than often seen in bullous pemphigoid. Next slide. The patient's often systemically ill, and clinically fulminant, acute, and subacute, tendency to involve the lower extremities, cellulitis that blends into the surrounding tissue, tense, shiny skin, and on the genitalia, it's called Fournier's gangrene. Next slide. And it's painful, limb and life-threatening, polymicrobial or monomicrobial. Most common is streptococcus for the mono. Surgery and antibiotics. They need immediate surgery. Strep contains a component called a spreading factor, and a spreading factor will make very serious disease, and it can spread along the fascia, and you need to get them to the OR quickly. Next. Cellulitis looks less dangerous. It's erythema. It's often warm to the touch when you compare it to a mirror image on the other extremity. Acute wound is usually gram-positive. A chronic wound with or without immunosuppression, we need to cover for gram-negatives and anaerobes. Remember, don't treat the swab, treat the symptoms and the signs of infection. Next one. What's the most likely diagnosis here? And this is again around the ankle. And this spreads, and it's also at the base of the toes. And you see the porcelain white areas, you see some hyperpigmentation, and you see some redness in the background. So what do you think is going on here?
Okay, and we'll share the results now.
And this is something that you may not always see, but it's important to recognize. And I get these consults from vascular surgeons saying circulation is normal, but this patient has got painful areas around both ankles, and but this not the circulation. And this is called livedoid vasculopathy. And in venous disease, you'll see a little bit of atrophy blanche around the malleoli, but not in the base of the toes and not extensive as you see in this patient. Let's look at the next slide. And this just shows a close-up of the porcelain white areas. There are some areas with red blood vessels and then post-inflammatory hyperpigmentation around those areas. The atrophy blanche is really ischemic skin in which the small vessels have all coagulated. Next one. Clinical features: painful ulcerative condition. Atrophy blanche is the smooth white scars. Surrounding telangiectasias, that's the red areas you saw. Andrew, just go back for a minute. And you can see some red areas coexisting with the hyperpigmentation. Next one. And hyperpigmentation, shallow ulcerations, but painful, really painful and difficult to treat. And you know, you may have seen this and not recognized it. Skin biopsy for histology. You can do immunofluorescence to rule out vasculitis, wound and tissue cultures. There are suggested lab studies for anti-factor 5 and 8 and C3 and C4. But if you do all the lab tests that are recommended, it costs over $800 for the patient in Ontario, and it does not change our treatment. Non-invasive arterial and venous ulcers. So you can see arteriolar and venous-like changes around these and associated with them. Next. First-line treatment is wound care, leg elevation, mini-dose aspirin or pentoxifylline. But really, recent evidence is low-dose oral anticoagulation. Rivaroxaban or Xarelto, 2.5 milligrams twice a day, and full anticoagulation is 20 milligrams. So this is really, if we're looking at it, a quarter of a full. Hyperbaric oxygen may help because they're ischemic. The pain you need to treat, nociceptive pain, acetaminophen is first level, a gram twice a day. Then you can move up to non-steroidal anti-inflammatories or even use those topically. So Voltaren Emagel or Emagel Fort is over the counter. And we have Pennsaid drops, which are Voltaren drops that are prescription. And those can be applied frequently without getting any of the non-steroidal in the bloodstream. And in persons over 65, more congestive failure, more kidney toxicity, and GI bleeds. So we have to be careful. Sulfasalazine works in some of these patients, 500 milligrams 3 times a day in intravenous immunoglobulin. So you see some of these treatments coming up more than once. Neuropathic pain, gabapentin or Lyrica, pregabalin. We may use things like tricyclics, nortriptyline, which is anti-noradrenaline. And you may need to treat both types of pain, but they require different treatments. Remember to ask somebody, 0 is no pain, 10 is slamming your thumb on the car door, and 5 is a bee sting. And most people tolerate a 3 to a 4. Next slide. Okay, developed an itchy red hive-like reaction over the legs and subsequently the rest of the body. The rashes being blistered in the last couple of weeks. New blisters are occurring every day. This time you see the blisters are filled with serum and they're not filled with blood. The redness is not quite as stark and quite as acute. And this is really itch that is driving the patient crazy. Next one. Impetigo, bullous lichen planus, burn injury, bullous pemphigoid, or epidermolysis bullosa. What is the most likely diagnosis here?
Alrighty, and you should see the results on your screen.
Okay, bullous pemphigoid and epidermolysis bullosa are tied here, but this is bullous pemphigoid. Next slide. And this is the skin biopsy shows fluorescence at the dermal epidermal junction. You see those pegs sticking down, and tense bullae, erythematous base, you biopsy the perilesional skin for immunofluorescence. Regular histology has a infiltrate of eosinophils, neutrophils, and sometimes some lymphocytes. Order lab including indirect skin antibodies for pemphigus and pemphigoid. In pemphigus, they get mouth lesions predominantly and early. In pemphigoid, it's skin and it's the elderly. And IgE level will measure disease activity. And a normal level in some labs is 100. And when this is active, it may be 400 to even 1,500. And you can watch that level go down. But what we do on the next slide is, and these are partially treated, but don't put iodine on these, please, because that's a pro-inflammatory stimulus. And this is what the partial treated skin can look like. Next slide. Topical ultrapotent steroids. Watch for secondary infection. Interlesional steroids, I inject around the edges. Tetracyclines, 1 to 2 grams a day, but doxycycline, 100 milligrams twice a day. And they should avoid direct sunlight, especially between 11 and 4. And sometimes I give the doxycycline 1 at supper. It only cuts down the absorption 20%, even with dairy. And or I use it an hour before bed with a full glass of water as the second dose. Systemic steroids, 0.5 milligram per kilogram per day. If I'm using the doxycycline and they're really bad, I might do that. So if somebody weighs 80 kilograms, I'd start with 40 milligrams. I decrease by 5 milligrams every 5 days. And I happen to know that's 180 pills. And steroid-sparing agents, azathioprine, mycophenolate mofetil, dapsone, and methotrexate. And I would put sulfasalazine alongside dapsone, as I always do. Next. This has changed how we approach bullous pemphigoid. And if you Google blister study and Lancet, this study will come up. It took 5 years, 50-some sites, and 253 subjects. And week 6, 3 or fewer blisters. 74% in the bullous pemphigoid, 91 in the prednisolone, but they adjusted for a difference. But look at this. Related severe life-threatening events by week 52, 18% in the doxycycline group, but 36% with prednisone. So double the severe life-threatening events, and deaths 3 in the doxycycline, 11 in the prednisolone. So we'll use, and instead of putting it on the skin, if it's all down the legs, I'll butter betamethasone 0.1% cream on a cling roll and then layer the cling roll up the abdomen, or I'll put the steroid even ointment on gauze and apply it. If there's only a few lesions, you might use a really strong topical steroid like clobetasone. Or if it's a extensive disease, you can get a pound of betamethasone 0.1% valerate. Sometimes you know it as Betnavate. But look at the deaths. 3 deaths in the doxycycline group, 11 in the steroid group. So you're 3.67 times more likely to experience a death on prednisone. Next slide. So we've got a differential of arterial, venous, mixed, osteomyelitis, cellulitis, necrotizing fasciitis, vasculitis, pyoderma gangrenosum, and even skin cancers, which I will not go into in this session, but certainly in some of the other sessions that will be a topic that we will explore. Next slide. So I have reviewed diagnostic criteria, evaluated testing, and assessed treatment. And it's important. In bullous pemphigoid, I do break the blisters and count the number of new blisters each day and keep a record. I might use Bactigrau on them. I might use something that's neutral, PHMB gauze. I might use, and if I was using something like a topical steroid, you could put it on a non-adherent and then use a silicone type dressing on top. Okay, next slide. All right, we are going into epidermolysis bullosa. And not only is this a rare condition, and you may not see a lot of patients with this, but it is a model for fragile skin. Next one. And there are many subtypes and over 20 variants, but there are 4 main subtypes, and you see different levels of disruption at the dermal epidermal junction. And Alex in that picture was a recessive dystrophic EB patient that we used Apligraf on, and because we were the first country in the world to get this licensed, I at Women's College would sometimes get 30 pieces of Apligraf because other than studies, nobody else could use it. We put it on with and without silver dressing and a foam, and with the silver dressing, it was preserved, and without the silver dressing, the Pseudomonas. And we realize now that red friable tissue is a sign of covert rather than overt or local infection. I didn't realize that then. Next. The dystrophic EB is the most severe one. And this is dominant or recessive. There's an abnormal type 7 collagen, which is the anchoring fibrils. And you get skin fragility, blisters, heal with scarring, milia, pseudosyndactyly. So the fingers all bind together like a glove. And you get microstomia, small mouth, ankyloglossia, kind of a tied down tongue, difficult oral hygiene, dental caries. And over the age of 20, they start to develop squamous cells, and they get more aggressive as you get older. Next slide. So I'm going to introduce you to Deanna Molinaro. And she's a patient I looked after for a number of years. At age 30, started to develop squamous cells on her lower leg and foot. And you can see that all of the toes and everything have all melded together. And she had had an amputation previously on the right hand below the elbow, and she's an artist, so this was difficult. In the right buttock, a resection and skin substitute. And she got a line infection, skin rash, and mucositis, and required, and this was probably secondary to the immunotherapy that she got. Next slide. So Deanna was faced with, they really wanted to amputate her leg. She had had 2 amputations, and what should she do at this stage? Should she have the right foot and lower leg amputated, have a conservative right foot amputation at the ankle, have a lower excision of the lesion and skin graft, correct lesions locally and heal by secondary infection, use local chemotherapy with 5-fluorouracil or imiquimod, which actually kills or stop treatment and use palliative measures. This is a very difficult thing, and this is where we realize we can't heal or cure everything in wound care. And once you get a maintenance or a non-healable wound, you have to start and turn to the patient and look at pain, look at quality of life, look at exudate, smell, and be able to give them the best possible quality of life imaginable. Okay, so we've stopped and here have a lower excision of lesions and skin graft. I actually curetted the lesions locally and let them heal by secondary intention. And you know, this is a very interesting outcome because Deanna died of a respiratory infection, not of her squamous cell. And for several months, we would have her back every 6 weeks. She would point out something that was painful or different than the other lesions, and depending on what they showed on dermatoscopy, I would freeze them and curette them. Next slide. And so this is what Deanna said to us, and let's listen to her. Deanna, you have epidermolysis bullosa, recessive dystrophic type, and you've had lots of challenges with the medical system as time's gone on. What would you advise doctors and nurses in wound care looking after this condition? How can they help you in the best possible way?
I think as a patient with RDEB, I think the best way medical professionals in any capacity could help is provide options and really listen to what the patient is saying. And the biggest thing is, like, I know my own body the best, and so does everyone else. And just listen and work together as opposed to following what has worked in the past. I think it's beneficial, and I don't know what the word I'm looking for is, but it's important to give the patient a choice in terms of which treatment options are available, whether it be wound dressings all the way to squamous cell carcinoma treatments, which is something that develops quite quickly with patients with EB. I've dealt with 4 bouts of it now in the past 6 years, and I've tried many different methods, and I think the biggest challenge was just managing my daily life and living my best life I could possibly live. And don't treat the patient in any, don't sugarcoat things is what I'm trying to say. It's a tough thing to deal with, but at the end of the day, we have to live with it and accept our own lives and make the best of them. So I think just offer different avenues of help, different pain methods to control pain, and just help the patient work together to live their best life.
Okay, let's look at the next slide. So what we did was we looked at squamous cell and EB patient, and there is a high likelihood of metastases and mortality. They also get malignant melanomas, basal cells. Surgical excision is the most common. But when we looked at the reported cases, and there were 300 and some, no significant difference in survival between different initial management options, excision, amputation, all other modes of treatment combined. So we chose a conservative route of curetting localized areas. And as we went on in time, less and less of them were squamous cells, and we did control this for quite some time. And for the quality of life issue, let's listen to Deanna's story.
Whether it's the finger painting of a child or a gallery masterpiece. The power of art to heal and to inspire is undeniable. Why does the simple stroke of a brush hold so much power? Allow me to introduce you to artist Deanna Molinaro to share the secret.
I like portraiture because I find people very interesting, but I also like surrealism. I tend to blend surrealism and realism because life is surreal. There are moments where you don't really know what to expect or what's coming next, and you kind of have to live each moment to the fullest. My name is Deanna Molinaro. I'm an artist from Hamilton, Ontario, Canada, and I was born with recessive dystrophic epidermolysis bullosa. So RDEB is the second most severe type of EB. Any slight trauma or just simply the progression of growth causes the skin to shear and blister, leaving behind wounds equivalent to third-degree burns. I was born in '92. My parents had no help here in Canada. They had no idea how to treat me. But over time, my parents and other parents like them, or someone being close to the cause, have helped change that. The community has grown exponentially across Canada and across the world. So yeah, it was just so different. I've been able to make so many connections with other individuals like myself, and it's so comforting to know that other people can understand what you're going through and you're not alone. As a child growing up with EB, my parents were very willing to let me learn what my body was capable of doing. So I remember always just drawing as a kid because I couldn't build with Lego blocks. I couldn't pull them apart. So my parents giving me crayons and a paper and pen and something that I found I could occupy myself with for hours. And then it just became a passion and something that I've always loved to do. My family and I, especially me and my mom, we have a really close-knit relationship with her being around me. For instance, every day she'll help me, take me to the washroom, put on my makeup, fix my hair, put on my wig. She's my superwoman and she does a lot for me. I'm fortunate to have people that care for me and are willing to kind of adapt their lives to help me live my own. Growing up with EB as a child, there wasn't even hope for just treatment on how to treat our wounds, let alone hope for a cure. So having someone like EBRP so dedicated to finding a cure is so uplifting and kind of reassuring for the future that maybe some child somewhere in the world won't have to deal with the things that I've dealt with in life. And researchers today are saying a cure is achievable within a decade. So if we rise up today, I do have hope that it will happen for the future generations to come, and hopefully sooner.
Deanna, you are a beautiful artist and an inspiration to me and all who know you. To everyone watching, please know that a cure for EB is just within reach. Researchers are working around the world and around the clock to make it happen. And when it does, we will cure EB and pave the way to curing thousands of other rare diseases. If you can, please help by clicking the donate button, texting Cure EB to the number below, or go to ebresearch.org to learn more. Thank you.
Okay, I do see 3 questions in the chat. And aside from biopsy, any clinical tips on how to differentiate between the hypertensive ischemic ulcer and calciphylaxis? It is a variant of calciphylaxis. It does tend to occur on the lower leg in the lower third of the calf, okay, or the gator area, and along the Achilles tendon. That's the first thing. Second thing, it's more common in elderly females without the kidney disease, but with hypertension, and they may have diabetes. You can differentiate it. If you can't do a biopsy, you can ask for ultrasound, and the ultrasound will often outline to you the calcium deposits in the skin, and you'll see these plates of calcium, which is what you see in end-stage kidney disease and calciphylaxis as well. And certainly the surgical management where or doing little bits of surgery as you go along will help. The second question was, why do we break the blisters in bullous pemphigoid? I thought that general blisters should remain intact for healing and decrease the risk of infection. The problem is that the blisters will start to spread and get larger, okay, because the skin is really compromised. And by breaking the blister, you take the tension off. You can leave the top on. Then you can put something like Bactigras or some antibacterial dressing on the surface of the wound. And, you know, you can sometimes even use the topical steroids, and then it won't stick to the wound on gauze or on a non-adherent dressing, and then use a silicone type covering. And that's best. But the blisters do need to be broken so that they don't track and expand and get bigger. And by leaving the top on, you are giving them some protection as well. But you have to remember the blister fluid in bullous pemphigoid is pro-inflammatory and will keep the inflammation going for quite a period of time. So that is an important thing to consider. And do you see pus under the blisters in bullous pemphigoid? Not usually, but when you do, when you break the blister, if pus comes out, you should culture that so that you know, and most commonly it's staph infection. And then you realize that even the MRSA staph, especially community acquired, is usually sensitive to doxycycline. So using doxycycline twice a day could treat the bullous pemphigoid as well. But then you may want to switch and use something antibacterial on the surface. And sometimes that's an antiseptic like hypochlorous acid. It may be something where you'd use Prontosan, because we do know that PHMB had the best therapeutic index for MRSA. Whereas hypochlorous acid had a very good therapeutic index. What is that? That's the toxicity to the host cells over the toxicity to the minimal bactericidal concentration. And for Staph aureus, non-MRSA, E. coli, and Pseudomonas, hypochlorous acid came in. And there is Pure Cleanse and there is VASH available. And these certainly would help in terms of the infection, or if you're trying to control the inflammation and the itch, the topical steroids, and sometimes we use, as I said earlier, we use Protopic on these individuals. Mm-hmm. Troy, I think you may want to do some wrap up.
Yeah, well, we had a couple of questions that I know that Jeff behind the scenes here with Perfuse has at least addressed a little bit. I hope you could talk to it a little bit too. So one's on about wound bed prep when using geko. So when applying geko or the muscle pump activator, should you ensure the wound is fully debrided first and free of non-viable tissue, or is it appropriate to use a device while there is still some necrotic or sloughy tissue?
You can use it with the necrotic or sloughy tissue, and that probably is an important thing, because increasing the blood supply locally can help the host defenses over the bacterial invasion. So we have no problem, but you know, cleaning off slough with two surfaces of different viscosity favors biofilm, and a biofilm favors bacteria over host resistance.
And then just continuing on the same subject, we had a question about using compression alongside geko as well. Is that safe to do as well? Should you apply it separately?
No, absolutely, it's safe to use. And the geko device is often above where you're going to put the compression on because it's right at the knee. And your compression should be 2 finger breaths below the posterior aspect of the knee so that it really is safe to use. And it sends a signal down to the foot to stimulate the actual twitch sign.
Perfect. And we had a question.
Dr.
Yeah,
can I
go
just
for it.
add to that is that we actually get better blood flow when compression is in place.
Yeah.
So that's an actual advantage to have the compression in place with geko.
Yeah, and what's happening is you're controlling the edema, and if you control the edema, and it's really interesting in a patient with arterial disease, and we've been doing sequential audible Dopplers. The audible Doppler from being a very weak biphasic with the geko device for a couple of weeks, we're actually getting an even better biphasic, almost triphasic Doppler. So it really is a way with compression controlling edema, but the geko also with the twitch response improves calf muscle pump action as well as increasing the local circulation. So you've got several mechanisms by which this is working.
Oh, thank you for touching on that. And speaking of, we talked about DFUs a bit last week, and one person was asking about if you had a patient with a Doppler result showing monophasic flow and they have a diabetic foot ulcer, would it be safe and effective to use the geko device? And are there any experience with this? What precautions or monitoring would you use in this scenario?
Yes, I have used it, and yes, it can help. You may not be able with monophasic to use compression, but the geko device still increases the circulation locally. But there's a certain stage at which, transcutaneous oxygen measures blood flow that if you've got blood flow below about 20 millimeters of mercury on the foot, it's unlikely that the geko or anything else is going to help it. But between 20 and 30, the geko or your hyperbaric oxygen may help. Whereas between 30 and 40, you may need, or you may see some slowing of healing, and this is where the geko may help as well. And over 40 is really normal. And what does transcutaneous oxygen measure? It measures the large vessels, the intermediate vessels, and the small vessels in the skin, along with any edema, any cooling, any drug effects. So how much oxygen is coming out on the surface of the skin? So really looks at a multifactorial component. Unfortunately, that's no longer covered as a service in Ontario.
Fair enough. And we've got maybe one more question here, clinical question, then we can have another one about the geko. But one person going back to our blister conversation here, is it okay to cover or appropriate to cover a blister with a transparent film dressing or an absorbent dressing to prevent it from popping? Or what considerations would you keep in mind for protection, healing,
I
infection
would
risk,
not
etc.?
do that. I would pop the blister and then cover it. Okay, because you got to remember the blister fluid contains a lot of pro-inflammatory components, and that's how the blister came in the first place. So you really want that blister fluid gone.
Fantastic. And well, I know we had quite a few questions that came in specifically about insurance coverage and costs for geko. Jeff, would you recommend that we maybe reach out specifically to Perfuse Medtec to ask questions about where in the country they're coming from?
Yeah, I think if they reached out directly to me, I'd be happy to answer the question because it's really going to be sector dependent, i.e. long-term care, WSIB, like workplace safety, ODSP with et cetera. So each province has a different coverage. So the important thing is to for me to understand where you're coming from.
Fair enough. And maybe I think that's a good segue. I know we're past the hour here too. I know there's still some great questions coming in, but as we wrap up, I'll remind everyone that we are recording today's session. So if you want to watch anything back or review some of the slides, you'll be able to watch it as a recording on demand on our website. We're also going to be sending a certificate of attendance to everyone who's come on live today with us. And one of the ways you can get in touch with Perfuse too, you can even reply back to that email with your certificate, and we can always forward you on to our team over there at Perfuse Medtec.
Troy, I just saw a question on high intensity needs, and it absolutely is covered by high intensity needs. That's been a big driver of a use right now.
Fantastic. Okay, well, with that, as I said at the beginning of the webinar, I'm going to remind everyone that this is just the first webinar of a series of, I think we're over 7 webinars now. It's going to go for the rest of the fall. We'll also be starting again, coming back into early 2026. So this is all a part of a larger project that we're doing in partnership with Perfuse Medtec, with the Canadian Home Care Association on advanced wound strategies in lower limb care. Our next webinar is going to be coming up very soon. I should know it off the top of my head, but I'll tell you now. The next one as a part of this series is going to be coming up on October 14th at the same time, 6 p.m. Eastern, 3 p.m. Pacific. So if you are interested in attending some more in the future, Dr. Sibbald will be on a couple of other webinars, and we'll be joined by Dr. Michael Stacey, Dr. Robin Evans on other webinars too. So we encourage you to check it out. Again, we'll put it in the email that comes with your certificate, but we hope to see you on a couple more of these webinar series. It's going to be fantastic throughout the duration of this year and early into 2026. So with that, I'll say thank you, Dr. Sibbald, and we will see you soon. And thank you to Jeff behind the scenes here. And Andrew, I know you've been working the slides behind there too, so we thank you as well.
Yep.
Have a great night, everyone.
And thanks, Dr. Sibbald.
Okay, thank you. Thank you, everyone. Bye for now.